Welcome to the University of Washington School of Nursing Voices of Nursing podcast, where we dive deep into the diverse and inspiring stories from the heart of healthcare. This is Voices of Nursing. In this episode of Voices of Nursing, we're joined by Anita Souza, Clinical Associate Professor and Psychiatric and Mental Health Nurse Practitioner, PMHNP, DNP, Clinical Placement Coordinator at the University of Washington School of Nursing, along with two community partners from Compass Housing Alliance, Liz Jarrad, Director of Advancement, and Tina Ellison, Director of Housing Services, bring their expertise from an organization dedicated to offering housing, shelter, and support for unhoused and low-income individuals in Seattle and the Puget Sound region. My colleague Jennifer Hunt spent some time chatting with them about their amazing community-based work providing care to unhoused older adults. Enjoy this episode of Voices of Nursing.
Welcome to the UW School of Nursing podcast. We have three wonderful guests with us today. We have Anita Souza, Tina Ellison, and Liz Jarrard with us today. And as we get started, I'd love for each of you to introduce yourselves and what your role is and what organization you're with.
Sure. I'm Anita Souza, and I'm here with the School of Nursing.
I'm Tina Ellison, and I'm the Director of Housing Services at Compass Housing Alliance.
And I'm Liz Jarrard, the Director of Advancement for Compass Housing Alliance.
Awesome. Thank you so much for being here today. We wanted to start off with Anita. She works at the UW School of Nursing and would love to hear a little bit more about your role and your academic and research background.
Sure. So currently I'm a Clinical Associate Professor at the School of Nursing with a focus in aging, but that's been a long time coming. I started in high school, actually working as a dishwasher in an assisted living facility. And I had a wonderful relationship with my grandma. And I thought, oh gosh, this would be perfect fit for me for a high school job. And what I fell in love with was the conversations that I had with those older adults when I was picking up the dishes. And I thought, can I make a career out of this? And so that's what led me in my journey to seek out a career in aging, and I was always interested in the research and the policy aspect. Worked at the Alzheimer's Association, serving the 23 counties that they served at that time, supporting individuals who were newly diagnosed with an Alzheimer's disease or another dementia. And then came to the School of Nursing to complete my PhD. And when I was completing that PhD, in my sample, there were multiple individuals in that sample that had PhDs and who were likely not representative of the population that I was interested most in what was happening with them as they were aging. They were definitely very interesting, but I'm like, where is this underserved population being represented? And they were represented in my volunteer work. And so I was doing overflow shelter work. And I was meeting those individuals who had Alzheimer's disease in the overflow shelter. And that's where I decided that's where I wanted to focus my research. And I wanted it to be community-based research. And that's where I partnered with Compass Housing Alliance.
Awesome. That's just so inspirational. And would love to hear a little bit more about your partnership with Tina and Liz.
Sure. Well,
you go ahead.
So that started, 2014. I actually met Tina's predecessor, and we had a conversation about issues of aging. And she said, our population is primarily over the age of 55 that we serve. And what could we do to partner together? And so we started by getting to know each other. It was a long process of me getting to know their organization, how they worked, who the population that they served, and then talking jointly about how could we help each other and what questions could we bring to the table for research that would serve both of our needs. And that led to participation in a community-based participatory research academy in Michigan. And then when Tina came on board, she took over that partnership and the collaboration. And we've been going strong since then. I'm not sure what you want to add, Tina?
I think what I'd add is that what was been really great about working with Dr. Souza and with the School of Nursing here at the university is the mission-driven piece, where we know that there are health components that exacerbate people who have lived homeless and people who've lived in poverty, extreme poverty, and their access to proper care and how their health impacts their ability to live a higher quality of life. And so having this partnership has allowed us to get some good research, but also engage in this more of a long-term 5-year research project to really look at how do we change policies and look at nationally even how this could influence incorporating a really intense level of health practice within permanent supportive housing projects.
That's wonderful. So can you tell me a little bit more about the community-based research project? What does that look like, and who are the players that are involved in that?
So for community-based participatory research, it's really the approach that we have. And it's the approach and the partnership together. And so this grant that we're currently involved in that was funded through the AmeriGroup Foundation, we partnered and said, there's a real significant health need in permanent supportive housing. Can we collaborate around our students and get our students involved in clinicals there so that they can support your population, get to know them, and hopefully then choose that path of community health down the line?
Yeah. Well, and I think that what's different is because I can imagine people are thinking, well, there are health clinics that people can go to, right? So why don't they just take them to a health clinic? This population that we serve and house and shelter are often distrusting of systems and services. They have fear. They have health complexities that they just don't want to bother, I guess, for lack of a better word. So what Anita and I have really focused on is the value of relationship and embedding the medical model into the housing model. So instead of it being an external resource that people tap into, it becomes an internal resource. So when our residents see the doctor just walking around the building, or they can participate in the meal program or participate in community events to build a relationship and have more organic, conversations, and then say, why don't you come and see me tomorrow at 11 at the clinic, and let's take a look at some of those things. And then they feel like they're just going to see someone they know and trust, not this stranger that they have no rapport or relationship with. And that has changed the makeup for sure. We are definitely seeing people who are engaging with our doctor that we have and with the students that truly, I don't know that we would ever be able to get connected at all. We actually, Friday, one of our clients at a different building who's having some pretty significant, what appear to be psychotic episodes, is willing to go and visit the doctor because we were able to really advocate and kind of do an introduction and things. But they refused for the last 3 months to go and see anybody. So just that impact alone could be transformational for him and kind of what's next for him in his housing stability. And that's our goal at Compass, right, is creating a stabilized housing environment for people, improving their quality of life, which incorporates making sure that they have really good access and attendance to medical attention. So whether that's dental, physical, psychiatric, whatever it might be. So I think we've been able to really see some benefits in that.
And the grant funding has allowed us to look at a medical model that is much more flexible and in tune with the patient population need. So this is not a 15-minute visit for medication management. This is, like Tina said, it's meeting you in the dining hall, talking with you, getting to know you. And the students are getting to see that approach as well of how do you build trust with a client who could have had an experience in medical care that was actually traumatic for them. We hear those stories a lot from these individuals. And so this is an opportunity to have a different approach, have the students learn that approach. And one thing we talked about as far as the community-based is always checking in with each other on how this is working. And we knew we wanted to build that trust, and the way to build that trust with the students was to have them there for an extended period of time. So typically at the UW, our quarters are 10 weeks long. We keep them there for 2 quarters so that the residents see those familiar faces again and again.
And I think the benefit, too, for the students is in this work, it takes time to build some foundational strength in having relationship and rapport with our clientele. And so they also get to see things through, right? They get to not just start projects, they really get to walk through them and see them to at least completion to sometimes, and sometimes just to a more advanced stage. Mm-hmm. And I think that that's a real benefit for the students who are participating, where they might not have that in a single quarter experience.
Mm-hmm. And so thinking of the students and their experiences participating in this research, what kind of challenges do they encounter in this research?
So I would say a challenge is that there is so much to know to serve a client in permanent supportive housing well. It's not just, like we've said, the medication management. It's also, we talk about this a lot, is the warm handoff, that there's a whole system of resources that you need to wrap around this individual typically. And the students often don't know what that network of support services looks like. And so this clinical immerses them in that experience. And I think some have initially said that's really challenging and daunting, but at the end of it, they're really thankful for that knowledge, because whether they end up staying in community health or moving on to another organization in their future, they're going to have that knowledge to underpin for their future patients.
And my guess, too, is that with some of the students that show up, I mean, obviously they choose Compass, and they choose Compass because it must tug at their heartstrings a little bit to work with this population. But to expand a bit on what Anita said is that I think it's really great for, even whether it's a school of social work, a school of nursing, any of them, to really be immersed into this population and into the living environment, to really see the complexities of people and really be able to look at what are people's baselines? When does that shift? Does it have to do with dietary? Is it lack of medical? Is it a situation happen and we're experiencing situational episodes, or the clinical depression or whatnot? And everybody being a part of this wraparound service. I mean, that term's been thrown around for decades, but this is really a way where the medical staff in this project are working with our case managers, with the property manager, with the maintenance team, all of those components. So we're really able to look at the big picture. So it might be, somebody can't take care of their apartment. So having the medical staff, or having the doctor or the student be able to show up and say, this might be a thing we should call an OT in, right? Get an occupational therapist in. Or we need a caregiver, helping become a part of the solution for the person, for their whole component. Like, do they need meals prepared? Do they need help with housekeeping? Do they need help with laundry? Whatever it might be. But we have more lenses with different expertises.
Mm-hmm. Wow. That just sounds like a wonderful, all-encompassing experience for people that need the care. And the fact that they can get those relationships with the doctors just sounds wonderful, especially with, what healthcare is today and some of the challenges I've heard, that there isn't that time to develop those relationships with patients. And so this sounds like an opportunity to do that. And it's really making a difference.
The other benefit, I think, with Anita's application for the grants is sometimes these projects might be being done to some component, but they're billing Medicaid, right? So what happens then if we have people who aren't on Medicaid, right? Because they're 42 or whatever it might be. And so how do you say, oh, you don't qualify? So this grant allows us to serve everybody regardless of what kind of medical coverage they have. And I think that part is something that just can't be overlooked. I think it also really supports the students and the doctor in doing their work. They know they don't have to worry about having billable hours, right, and billable time. So that part has been, I think, pretty transformational for not just us, but for for the medical team.
Mm-hmm. And I would also say that we've been pleasantly surprised by, placing a PMHNP on site and placing a student, and most of the students have wonderful backgrounds as psych RNs, that education that they have is also passing to the staff at Compass and to the case managers. And they're learning a lot more about the medical care and how to approach some of these challenging behaviors from the perspective that the PMHNP has and the nurse. And that's been fantastic to see that bidirectional information sharing.
Yeah, the training, that part, like teaching kind of on the spot, I think it's reciprocal in learning different ways of handling behaviors or people's, kind of what they're going through. But definitely just for staff, if they've dealt with somebody who had a traumatic experience or they had to revive somebody from an overdose or something like that, to have, the doctor and the students on to also be able to walk through that and how are they building their resilience has been really helpful as well. So just that emotional support available for staff, but also talking and case conferencing about what are some other ways to approach someone's behavior? How are we quickly assessing? Is this just oppositional behavior, or is this a drug-induced psychosis, or is this something else? What might it be? And having an expert at that level there to consult with has also been really transformational in terms of the support and the confidence and building competencies in our staff as well.
Yeah, I'll just add that this feels like the missing puzzle piece that kind of completes the PSH picture or the PSH puzzle. We have been operating housing at Compass for decades. Compass is a 100-year-old organization, but we've never had such embedded medical model in our programs. And, PSH, for those of you who aren't aware, are for folks with significant barriers and needs who've had chronic homelessness, who have a complicating medical mental health diagnosis. And the staff in our programs are experienced case managers, experienced social workers, and program managers, but they're not doctors or nurses. And so, it's quite often we hear heartbreaking stories where there are residents who are just beyond our scope of care. And we run into that on a fairly frequent basis. And so with this partnership, we've been able to kind of ease that, as I guess it's appropriate to say. So it's also just supported for our staff because we have a high turnover rate. We have a high burnout rate. And we need more solutions to support our staff, especially our residents, right? And so it all fits together in a nice picture, I think.
Yeah, I could see how that would be so beneficial because if you're in that situation where you don't feel like you have the training or background, it would be really beneficial to have someone there that can guide you through.
Or even just the speed, right? Like getting an appointment. Even if our staff have a client who's like ready today, right? So they say, yes, I want to go see a psychiatrist or somebody. So we have access, but it's 10 weeks out. So whatever happens between now and 10 weeks might put their housing at risk, but also in 10 weeks, they might not be ready. So having someone who we know is going to be there on certain days of the week, because they're not there full time, they're part time, but we could get the client in to see the doctor on a Friday. So we know that. So the window is much more wide open than having this sliver that's way off in the future. Because if anybody knows anybody who, it could be a medical condition. I have a cough today, and you go, oh, I'll go to the doctor, but you can't get in for 2 weeks. And you're like, oh, I'll just live with it, right? And then if you're having a mental health crisis and you feel somewhat ready right now, that readiness does not sustain. So the fact that we can get them in quickly is a massive win for not just our system, but for that person that we're trying to support and help with their quality of life. We house people at Compass, especially in our permanent supportive housing programs, that would not get housed other places, right? So I worked for a housing authority for 16 years. We house people who probably would not get housed or be able to keep their housing there because of the barriers that Liz referred to. The level of their disabilities, the chronic homelessness, just that culture. And so to keep them housed takes, it's cliche, but it takes a village to raise a child. It kind of takes a village to support our clientele. And I will say this, that the students and the staff that Dr. Souzza has got recruited for this project, I feel like are just a beautiful part of the village. Like everybody's really driven and wants to love on these folks that we feel at Compass always privileged and honored to be in relationship with and care for. I think all of us will often say, like, I can't believe somebody trusts me with their story or with their heart. And so the team from the UW has also really embraced that. And that's what makes it also work, is it's not just your learned skills and talents. It's really looking at what kind of people choose this.
Wonderful. Well, speaking of, so Dr. Souzza told us earlier a little bit about why she was so passionate about this field and her early life experience. So I'm curious, Tina, what got you so involved and passionate about the work that you do?
So I've been doing this about 38 years now. So I know. I'm only 40. I'm not sure how that happened. So similar, in high school, in the early 80s, I was actually a volunteer at an orphanage. And I think I was 16 and just fell in love with loving on people who had been, for lack of a better term, thrown away. And just feeling that no matter what a person's story is or what they're demonstrating in the moment, that they deserve to be loved and they deserve to be seen and valued and welcomed. And that doesn't mean you don't have boundaries. It doesn't mean there aren't consequences to bad choices. It just means as a human, those are some fundamental things. So we think like everyone deserves a home at Compass. That's our slogan. We believe fully that finances determine the size of your home, not whether you should have one or not. So I think I've just incorporated that into my life's work to make sure that, walking by people on the street even, that they get eye contact or a hello because they're someone's child. They could be someone's parent. And I feel like for me, I'm a woman of faith, and I just feel that in order to walk in that way, that I just look at people through a loving lens. That doesn't mean I don't get frustrated or upset about things sometimes, usually systems, not people, as most of us can relate to. But so I think that just sort of drew me into working and then going into administration, because I'm definitely big on now making sure we have systems and policies that support both the people that we're serving and our employees to help create a sustainability in this workforce as we move forward.
That's so inspirational just to hear, kind of your background and what's inspired you to be part of this work. Do you have something you want to talk about too in terms of your inspiration? Okay. We're all getting over some colds and runny noses.
Yeah. So, I'm very inspired by this work. I've been with Compass for 9 years, a majority of that time working alongside Tina. And I originally came from the mental health world. I got my master's degree, focused on trauma psychology, and was actually a trauma therapist for a few years for women exiting homelessness. So this is, for some of them, the first time in decades that they had felt safe, right? And so I got to personally witness women come in from outside, literally from survival for usually decades, sometimes since they were preteens. And I watched it set in that they were safe, that they were provided for, that they could trust the walls around them and the people in those walls. And then I watched them open up and be able to unpack a level of trauma of which, I've still never witnessed in my life except for through this population. And this is the exact population we serve at Compass. And so really, as a therapist, it clicked for me that housing changes absolutely everything. And without housing, we don't have good healthcare. Right? The impact on healthcare system, we're seeing it. And that's at the best, right? Look at all the people that are dying still, right? And so I feel really passionately that housing changes everything, and it absolutely is a form of healthcare. But once we're there, okay, now we need to get down to business. And this is really what excites me about this partnership.
Yeah, and I think Tina talked about capacity, and when we bring a student along in this work, we're able to increase capacity dramatically, especially with that 2-quarter model. So once they build up their confidence and their competency, they're able to take on some cases independently, and they often do have independent caseloads at Compass, and that's lovely for their learning experience, but also for the demand and the need at Compass.
Mm-hmm. Yeah, it sounds like a very highly successful model. So I'm curious, has this expanded? Like, are you the first ones to trial this and hoping to expand it to other areas in our state or across the United States?
Well, that's the research.
That's the research question.
So this is definitely what we would consider a pilot program. And I think just within Compass alone, it would be lovely if we could expand this model, because Compass is not just permanent supportive housing, they also have shelter as well. And it would be lovely to have that support within shelter and within permanent supportive housing and have the ability to meet that demand. And the feedback from the students is that they really have appreciated this clinical opportunity. We know that there's such a tremendous need out there. We would like to continue to train clinicians to support this population. So I think it's probably dependent on funding resources, to be honest. So we certainly would like to continue with additional funding.
I would say, too, we learned a lot, right? So in the beginning, we thought, we'll just have this doctor and the students take on all of our Compass sites, right? And we have like 15 housing sites and we have like 4 shelter sites. And so we'll do that. And then we realized like that's too spread out. So we had to reel it back in. And so we've had to try a couple of different approaches so that we could really get the impact for the research so that we could grow it better. And at doing that, I think that that's been a good takeaway, is looking at the model doesn't work when it's spread thin. It really needs to be a bit of a saturation of focus, because that's how relationships are built. So we've learned a little bit about that. And I do think that, there are other models around with health and housing and things like that. It's usually in partnership with like people being responsive or, again, an external. This is really, truly one where it's just embedded and a part of our team. And so, again, that's that wraparound service part. So no stone is unturned, doesn't get turned over kind of a thing when we're looking at what are the possibilities. And that wouldn't happen with somebody just, coming in when we call on them. They know everybody.
Yeah, I would say the system is built on crisis response. And I think we know it's not quite working for everyone it should.
Right.
And so then what's the different way? And I think that's what's beautiful about this, is that we're seeing the different way happen, and I'm seeing some exciting outcomes. I don't know if we're prepared to necessarily share them now, but that's one thing that I think will be really compelling to share. Yeah.
I think the thing I was thinking of too when you were talking, thanks Liz, was also I don't know if it's this model, but something similar to some capacity happens in prisons, in like memory care facilities. So we wait until there's a place where people are secured, for lack of a better word, to have access with something like this. And why are we waiting for that? Right? Well, why aren't we taking a more preventative approach, an early intervention approach to impact people's ability to live independently, have a good quality of life, and before that happens, so before their end of life expectancies or before an incarceration. Chances are some of our folks would not need to be incarcerated if they had stable housing that was meeting their mental health needs, right? Because how many people are incarcerated because of mental health impacted behaviors? We have to hold people accountable to behaviors, but how could we have prevented that with some intervention? And I definitely think over the model of this research that if we might be able to look at some comparisons in that and see. We've already seen the housing stability impacted. I can think of at least 2 people who I'm pretty sure would not be housed with us at the site that we have these services embedded in without them, because they wouldn't have gotten the medical care and gotten the medication and then the med management on it. So, I mean, I know there's more, but I don't work there full time, so it's like I know 2 on the top of my head. So.
Well, and there's a limited amount of permanent supportive housing that's available. And so the prioritization for permanent supportive housing is often for individuals with multiple chronic health needs, right, that have been unmet. But we don't have a good system yet for delivering that health care. This is a nice model for delivering that health care at the point of need.
Mm-hmm. Well said.
We know housing saves the healthcare system money. We know it saves the justice system money, right? We know that on the whole, it is a better investment of taxpayer dollars to bring someone inside and house and care for them than it is to leave them on the street. And so how can we leverage those solutions within the housing model and continue to help realize savings? Yes, indirectly, but also the cost of human suffering is high, right? And I think that's where we're getting at.
Absolutely. And the health profile of the individuals at Compass, they're primarily over the age of 55 in this current building that we're working with. And they've got significant health conditions, including memory loss. And I think back to my days in assisted living. So when someone came into assisted living, we did a workup. We did a whole history and assessment of what was their health conditions. That doesn't happen in permanent supportive housing. They find out about it as it unravels for the individual, and it often unravels pretty quickly once they move in. And so this is an opportunity to catch some of that for individuals.
And people who live unhoused can't get, like if they need surgery, you can't go in for surgery and get released to a shelter, right? So there are people who probably die outside. That's totally preventable if they were housed, because they would be able to get the surgeries that they need and then have a safe, warm place to return to for healing. So, just those impacts alone, just from a human perspective, is important for us to not ignore.
Yeah, if there's any average Joes listening to this, folks who maybe aren't PSH folks or even medical professionals, maybe you all have experienced being in a 15-minute doctor appointment where you feel like you really need to advocate for yourself hard, right? You need to vie for that extra time to ask those questions, to ask for clarification. You need to double back and understand your health, like what was directed to you or your treatment plan much better. And for me, I've struggled with that even in my own personal life. And I feel very equipped to advocate for myself. I'm sharp, I'm smart, I'm housed, I'm not hungry. I don't have basic needs clouding my ability to advocate and care for myself. And there's a lot of privilege in that, I think, that we sometimes forget to acknowledge. And so someone out there may be thinking, well, that seems like a lot for a housing program. But when you start to think about that experience for someone else who doesn't have the resources and capacities that maybe I have as a housed person, then you see where it becomes very necessary.
I can think of some families. So because we do house a vulnerable population who are aging, we definitely experience some, end of life situations. Sometimes it feels like quite an honor that they got to die at home and surrounded by people who care for them. But lots of family members who we reach out to are so grateful that their loved one that had a history that led them to some homelessness and led to the relationship that they may have had with their family member to be severed or distressed, for them to have a healthy boundary and to not place judgment on that. We don't know what happened. to be grateful that we loved their family member through really hard times, and they often experience those hard times with their family member, but knowing we embraced them in spite of those things and worked at trying to get those broken parts healed has been really quite a privilege as well. Just knowing that when we look at the folks that we're housing, like, they weren't born this way, right? The world happened, and whatever transpired doesn't mean that they get tossed away, and we don't want them outside. I don't want them dying on a curbside. And so we want to make sure we're doing what we can to save their life and impact their health and improve their quality of living. And then if it is the end of their life, that they're surrounded by people who they feel seen by and cared for. And we know their family members are grateful. We have letters from families who say, "We know how hard my mom is. Thank you. Thank you for loving her when we couldn't." And that's an amazing gift. And lots of them have seen their family members improve their health, their mental health, their physical health by living with us. And some of them have been able to rekindle in their relationships, even if it's been little bits at a time. Those are big wins that don't have monetary rewards, right? No one's writing us a check because we saved their mom's life, right? But the checks in our hearts are pretty big, and our mission is really valuable. Not that Liz wouldn't love a big check from somebody as our advancement director, but yeah, I think that there's, the compelling part of the heart of this work, the mission of this work, is that whole person, and that's what the partnership, I think, has allowed us to do, is to look at how do we really, in a better way, impact people. It almost sounds like if I was talking to my grandmother, that she would say, well, that's how it was when she was a kid, right? I mean, she would tell stories about how the doctor would come to the house and they'd bake a pie and, whatever. It's like we need to go back to the old school medical model where people mattered. And it wasn't the 15-minute billable transcribing or what's it, transactional relationship, that it was really about relationship. And I really believe that those of us in social services and in the medical field get into it because we care about the human part. And so this allows us to really foster that, right?
And it's wonderful for the students to get to witness this interaction and take away some of those questions to ask of individuals as they're moving forward as well. So asking about their housing, asking about their family relationships and dynamics in a different way than they would have asked probably in a 15-minute typical clinical visit.
Mm-hmm.
Yeah.
Yeah. No, it's really been a win.
Wow. That's wonderful, and just inspirational work that you're doing on the research side and the direct service side, working with people who deserve this care throughout their lifespan. So Dr. Anita Souza, Tina, Liz, thank you so much for joining us today on the School of Nursing podcast and sharing your inspirational work and your partnership, and just wish you all the success as you continue this model, and hopefully it will expand into other areas and beyond.
Thank you so much.
Thank you.
Thank you so much for your time.
You.
Yeah.
Thank you for tuning in to University of Washington School of Nursing's Voices of Nursing podcast. Join us next time as we continue to explore topics vital to nursing, health, and well-being. Until then, stay informed, stay inspired, and stay engaged. And don't forget, follow Voices of Nursing wherever you listen to your favorite podcasts so you'll get every show as soon as it's released.